and go live, Andrew? Will you let us know?
Good morning, everyone. We're live.
Hello, good afternoon, everyone. Welcome to the first meeting of the Massachusetts Health Policy Commission's Advisory Council. I'm David Seltz, Executive Director of the HPC, convening today's meeting. It's so great to have everyone here today, this afternoon. Happy February, happy Black History Month. I hope that you and your family and friends are all well. It's a gorgeous winter day here in Boston, which feels appropriate, with some good encouraging news coming out today on the COVID vaccine front. So enjoy that sunshine if you can. I want to welcome our advisory council members. Great to see so many familiar faces as well as some new ones. And also, of course, welcome to the public and other stakeholders who are watching this meeting live on our YouTube channel. Thank you for your continued engagement with the Health Policy Commission. So 9 years ago, one of the first activities of the newly established HPC, we convened the first HPC Advisory Council. The goal of the Advisory Council is really to enhance the HPC's policy discussions by allowing for varied and representative perspectives on the issues facing the Massachusetts healthcare market in order to advance our goal of a more affordable and equitable healthcare system. We use this advisory council as really an opportunity for open dialogue and engagement with a really excellent and diverse group of healthcare stakeholders and policymakers, which really just contributes so much to the work of the HPC. For those of you who have been on the advisory council for many years, you know how lively these discussions can be. And we really think it's a great opportunity for not only for you to be able to share information and guidance and counsel with us at the HPC, but also to be able to engage in a conversation with each other. So we try as best we can to preserve as much of this time here together to have that type of discussion, and really tried our best here today to reserve the bulk of today's meeting for our conversation. We're so thrilled that this group, that so many of you asked to be reappointed to this group. We really, again, appreciate your time and commitment to participation. We know how much demands you have on your time. And I will say we are at the beginning of a very busy period for the HPC. And so expect that we will be calling on you early and often in the coming months to help us guide this work. So today, our primary topic of conversation will be on a new HPC study on the impact of COVID-19 pandemic on the Massachusetts healthcare system, specifically its impacts on access, quality, healthcare costs, workforce, and market design. This was a newly mandated study in a recent healthcare legislation, and I'll talk through a little bit about what the legislative language there includes. I have to start by saying you and your organizations, every single member of this advisory council, have been so deeply engaged and a part of the COVID-19 response on behalf of your organizations, the communities you serve, the patients you serve, and we are all just eternally grateful for the way that the Massachusetts healthcare ecosystem was able to really come together to address this deadly pandemic. And we think that as we begin this work of trying to understand impacts and also trying to inform future policy conversations, that your input and expertise and perspectives will just be really invaluable. We look forward to starting this conversation today, but recognizing that the pandemic is still ongoing and the future, while hopeful, is still uncertain. Recognize that this will be the work of this entire calendar year and probably beyond for the Health Policy Commission. And while that's our primary topic today, I would also mention that in addition to the new COVID study and a few other new mandates from the legislature, the HPC, of course, continues to execute on our core responsibilities, including setting the healthcare cost growth benchmark, monitoring spending and pricing trends, issuing our annual cost trends report, monitoring changes to our healthcare market that impact costs and spending, and all of the other incredible programs and investments that we're currently pursuing. So it's a very busy year with a lot going on. But before we turn to today's discussion on the COVID impact study, we wanted to provide a welcome to some new advisory council members to preview our upcoming hearing on the healthcare cost growth benchmark and provide just a brief update on the HPC's internal health equity agenda. And so to give us those updates, I'm going to turn it over to my partner and yours, Deputy Executive Director, Colleen Elstemeyer.
Thanks so much, David. Good afternoon, everyone. So wonderful to see all of your faces here. As David said, yes, this is the first advisory council meeting of this new 2-year term. So 2021 to 2022. We are excited to have many of you back and also to welcome some new voices and perspectives that will contribute to our priorities for this year. So listed on this slide is the whole council. You'll see the new members highlighted, all incredibly accomplished people doing extraordinary work. I don't have time, unfortunately, to go through the whole council membership, but I do want to give just a minute to our new members to let them introduce themselves. I'll call on each of you in turn, and I'm going to start with Liz because I know she has to leave us a little bit early. So Liz, if you could get us kicked off, please just introduce yourself and tell us a little bit about your organization.
Absolutely. I'm Liz and I live and work in Springfield and came to know about this group specifically through a grant that a collaborative group I'm a part of that includes Mercy Medical Systems, Trinity Health Systems, is participating in that was funded by the HPC. Our work is deeply focused on food, and the work of the Food Policy Council is really informed by our understanding of the need for policy systems and environmental change, and the understanding that the constructs that exist and that provide barriers to equitable food access, healthy food access in particular, are public health issues. I live in the county that's ranked the worst by Robert Wood Johnson for the Commonwealth. We have every food relatable, preventable disease imaginable, and I've seen it play out in terms of early COVID deaths. We've lost 2 members of our steering committee to COVID that had comorbidities, and very recently the chair of our steering committee succumbed to a massive heart attack after a lifetime of not having access to healthy foods that would prevent these diseases. And so I'm thrilled to be a part of this group. We talk about race all the time in our work because these constructs grew directly out of the legacy of slavery and the ongoing systems that have been put in place, anchored by white organizational culture and white supremacy. And I think we have to build our muscle to talk about race in the same way that we talk about behavior change, which we're all really comfortable with, and yet not comfortable recognizing that you can't change behaviors when, like in my neighborhood, there are 10 McDonald's within 1.75 miles of my home and no farmer's market, produce stand, or full-serve grocery store. So I'm thrilled to be here and hope that I can bring some value.
Thank you so much, Liz. We completely agree. Okay, turning it over to Lizette next. Welcome, Lizette. Are we have a mute situation?
See, I had told you everything about myself and you didn't hear it. I am thrilled to be here. I had followed the work of the commission for a long time and very much respect what you do and love the possibility of bringing a different perspective or an additional perspective to the table of community health workers. I want to agree with what Liz just said about the importance of the race conversation. And I will add to that class and how race and class really have determined so many of the health outcomes that are very preventable if we addressed those inequalities. MACHWA is a professional association of community health workers. We have about 3,000 community health workers in Massachusetts. Most community health workers come from and live in the communities that they serve, so they understand firsthand a lot of the issues of class, race, and health of their clients and are able to address them in very effective and efficient ways. MACHWA is organized through, right now we have 3 regional chapters, one in the greater Boston area, which we're just launching, one in the southeast region of Massachusetts, and another one in the Pioneer Valley of Massachusetts. We're hoping to have 3 additional ones, but the idea is to be an organizing entity for this very important workforce, to not only identify the issues that they are facing in real time and respond to them, but also to celebrate and promote their many accomplishments. I'm really thrilled to be here.
Great, thank you so much. Okay, I'm going to turn it over to Kim now. Kim Brooks.
Hi, Kim Brooks. I'm the Chief Operating Officer of Senior Living for Hebrew Senior Life. We are an organization that serves about 3,500 seniors every day in and around the Boston area. We're in all different businesses and service lines, but all focused on seniors and redefining the experience of aging. I would say from a priority standpoint, one of the priorities for us that is most significantly aligned with the current HPC areas of focus is in social determinants of health, and most particularly in affordable senior housing and the integration of care in housing. So we do a lot of work, not just with housing as a social determinant itself, but really as a platform and a way to deliver a real, high quality to seniors, improving the quality of life, as well as having a significant impact on cost to the system by using that efficient and effective platform of housing. So I am excited to bring the perspective of senior care and really honored to be part of the group. Thank you.
Thank you so much. Okay, I'm going to turn to Lisa Gergon from Mass Home Care.
Hi, everyone. My name is Lisa Gergoni. I'm the Executive Director of Mass Home Care. We are the trade association representing the Commonwealth network of 28 aging service access point area agencies on aging. Really excited to join so many friends and colleagues here on this Zoom call today. We work specifically to provide home and community-based services to the over 60,000 older adults in our Commonwealth who remain in their home. The people we serve are probably the most vulnerable in older adults in our Commonwealth in need of really services to allow them to stay home. We do Meals on Wheels, home care, protective services, just a variety of services to support those individuals. So exciting to be here. Prior to this role, I did work in the home care aid industry. So I also understand the direct care workforce, and I know that's such a critical component. And I also welcome the conversation that this group can have to kind of make sure that we're thinking about the workforce very broadly when we think about the healthcare system. So thank you for having me.
Thank you so much for being with us. Sorry, I pronounced your name incorrectly, Lisa Gergoni. Okay, Michael Curry and Ellen LaPointe aren't with us yet. They might join the meeting a little bit later. So I'm going to have Deb Wilson bring us home with the intros.
Hi, everyone. And I'm Deb Wilson, the CEO of Lawrence General. I am very happy to be on this council with all of you, looking forward to the dialogue, looking forward to making a difference. In the way of background, I was appointed the CEO 1 month before COVID hit. So everyone tells me my timing is impeccable, but I have been here for 10 years. And prior to that, I spent 12 years in Brockton. So I definitely, I've spent a lot of time in underserved communities, Brockton and Lawrence. And I will say that the inequities are real. They need to be addressed. We have data that shows that the COVID mortality rate for Hispanics was more than 7 times post-COVID than it was before COVID. So this is a population that absolutely needs for us to stand up and really deal with these inequities. We were a hot spot. With COVID, we partnered with the city and the state. We did more, like about 1,600 COVID tests a day at one point, and we're now doing over 1,000 vaccines. So we feel that we have a role to play in helping this community from a public health standpoint, but we also want to make sure that community hospitals that serve the underserved are actually vital community assets that are sustainable. And again, thank you so much. I really look forward to the conversation.
Thank you so much, Deb, and thank you to all of you, our new and our returning members. We are looking forward to working with you over the next couple of years, and we know this year, like last year, we'll bring a host of new challenges. We couldn't do the work of the HPC without you all and our broader stakeholder community, so thank you for your involvement. And just a heads up, our new membership's also posted to the HPC's website as of today, so feel free to check it out there. All right, on the next slide, I just have 2 more slides for you all, and then we'll get right into the discussion. It is hard to believe, but we are about to host the benchmark hearing, our annual benchmark hearing, which, fun fact, was the last public meeting we had last year, just days before the lockdown. So the HPC's annual hearing on the healthcare cost growth benchmark is a month from tomorrow, Thursday, March 25th at 12 p.m. Under the framework set forth in Chapter 224, which is the HPC's enabling legislation, the HPC's board may modify the benchmark established in statute for calendar year 2022, and as required by law, will set the benchmark equal to potential gross state product, or PGSP, minus 0.5% or 3.1%, unless the HPC determines that an adjustment to the benchmark is reasonably warranted. So because, it's just to oversimplify, because PGSP was set earlier this year at 3.6%, the default is 3.1% unless our board votes to modify, votes to change it. So the annual benchmark hearing is an incredible opportunity. We co-host it with the legislature's Joint Committee on Healthcare Financing. And it's an opportunity for our board and for the legislators to hear feedback from market participants and stakeholders and other interested parties on whether modification of the benchmark is appropriate. So looking for your help there. Many of you provide live testimony or written testimony every year, and we're hoping you'll do that again this year. But this year, we're excited to welcome Dr. Michael Chernew as a guest speaker at the hearing. He's the Leonard D. Schaefer Professor of Healthcare Policy and the Director of Healthcare Markets and Regulation Lab in the Department of Healthcare Policy at Harvard Medical School. So Dr. Chernew will be with us to discuss national trends in healthcare spending and pricing, and we're looking forward to that. So the hearing will be live streamed just like this meeting on our YouTube page. We encourage you to please email Ben Thomas, who many of you know, his email's on this page. He's our government affairs manager, to sign up in advance for live testimony. We'll only have advanced sign up this year, or to share written testimony. You can get more information from Ben there. Thank you so much. And on the next slide, just a really quick update on one item before we turn to the agenda. As I've said previously, we've discussed previously, the advancement and promotion of health equity, and equity in healthcare is absolutely integral to achieving the HPC's mission. And we're really, as all of the members, our new members have said, are just really interested in the intersectionality of health and racism and racial justice. So we greatly appreciate the advice and expertise that many of you have taken time out of your days to share with us in developing our framework and our goals for health equity, and we continue to welcome that help. Our overall goal as an agency is to integrate an explicit health equity lens into all of the work of the HPC. So all current and all future work will be viewed from an equity standpoint. So this is just a really brief update on 3 new projects that I just want to share with this group. The first is a new health equity practice and style guide. As we have done the work to apply the health equity lens to all of our work streams, it's become apparent that as an agency, we need common principles and vocabulary for how we talk about issues of equity in all of our work. So the purpose of this guide, it's an internal guide, is to begin to codify standards and guidance in a manner that can be useful to all of our agency staff. So broad principles, communication best practices, preferred terms, a glossary. It's really important that we're all talking about these issues in an aligned way. So this is a product I'm really proud of, an internal working group. Our staff did this on their own. They spent many months developing this. It's a gold standard resource and a practical tool to help with decision making. And we're going to be rolling out this tool internally in the next few weeks. So excited about that. And then just second here, we're grateful, as always, for our ongoing collaboration with our sister agency, the Center for Health Information and Analysis, affectionately known as CHIA. And we've made a new public commitment with CHIA to use our combined resources and agendas to evaluate which data is available to us, what is needed, what steps will need to be taken to obtain data to ensure our work in this area isn't hindered by lack of access to key information. So that's a partnership that we're engaged in with CHIA. And then lastly, just touching on our commitment to developing new agency-wide metrics and goals. Our intention is to set HBC's goals that are actionable, measurable, to track progress on our health equity efforts. And these are derived from all of the action items that I've discussed today and previously that all of our teams at the HBC have identified as ways to support and further the incorporation of a health equity lens into everything we do. So please let me know if you're interested in supporting this step of the development. This is the next step of the development. So if anybody is interested in working with us, and I will absolutely reach out to you all as well, just feel free to give me a shout. Okay, that's it from me, David. I'm happy to take any questions. I'll turn the reins back over to David Seltz. Just please stay on mute during the meeting to avoid feedback and any other audio issues. If you would like to make a comment, as you all know, I see that you're all already doing, please indicate so by using the raise hand function, and then David or I will call on you to speak, or just send me a private chat message. I will maintain the queue, and it's usually a very lengthy queue throughout the meeting, and I'll let you know when it's your turn. So thank you so much. David, turning back to you.
Colleen, I think we have a few questions both in the chat, and I think Colin wanted to make a comment as well.
Okay,
Yeah.
well, I'll start with Colin as I review the chat.
Fantastic, thank you. Very happy to see this, and just wanted to say, please do reach out to us. We've been having conversations with DPH about improving their disability data collection. Would love to work similarly with you folks on that, and likewise, been working with Blue Cross Blue Shield of Mass Foundation on a similar style guide for them, and we have some disability points to contribute. So looking forward to working with you.
Thanks so much, Colin. Appreciate that comment. And Carlene Pavlos from the Mass Public Health Association had a question for me as well, if I could paraphrase, just asking if we were planning on sharing the guide widely. And yes, we will expect to make that a public resource, and we'll certainly share it with our advisory council for feedback before we do release that publicly. So yes, we'll be happy to share that widely.
And would welcome feedback and suggestions as we put that together, and recognize it may be a little bit of a living document as we continue to educate ourselves and improve. And great to hear, Colin, that there's others out there doing similar type of work, and we'll want to make sure we're aligned with that. Thank you.
This is Donna. May I make a comment? There is legislation filed from Senator Friedman, in case you haven't had a chance to take a look at it yet, that does set some new data reporting aspirations related to behavioral health, and a role for CHIA in that, aligned with the work that the HPC does for all of health. So if I can send it over to you if you haven't seen it yet.
That would be great. Thank you.
Thanks.
So thanks, Colleen. Anything else to add? Okay. So great. Thank you for that excellent update. So we're going to turn to the primary topic of conversation today, and usually I feel that sometimes we overload the agenda with all of the topics because we're so deeply invested in all of the different areas of work of the HPC. But we're going to take a little bit of a different tack today and really focus on one really significant and big topic, which actually within it includes all of the issues that have already been raised and kind of brought to light through some of the introductory comments today. And that's this new legislation, which is summarized on this next slide here, that was part of a comprehensive piece of legislation that the legislature passed towards the end of last calendar year and was signed by the governor on January 1st. An act promoting a resilient healthcare system that puts patients first. This is a really important piece of legislation, and I am not going to try to attempt to summarize all of the critically important advancements within this legislation. But one of the big pieces that impacts the Health Policy Commission is a number of studies and research mandates for us to be able to leverage our expertise, our staff, our data, and our connected community, of which you are a part, to begin to examine and understand the impact of COVID-19 on the healthcare system, and not just to understand past impacts, but as I mentioned before, really to help inform the future of healthcare in Massachusetts, the structure of healthcare, the goals that we want to set for ourselves, the lessons learned from the past 11 months, and how that may inform how we can build, as the Act says, a more resilient healthcare system that puts patients first. So summarized on this slide is really some key bullet points from the legislation itself. It charges HPC in collaboration with CHIA with assessing the impact on accessibility, quality, and the cost of healthcare services, as well as the financial position of healthcare entities, which broadly includes both healthcare providers and health plans, and the implication of those effects on long term. The legislation is quite ambitious in terms of both the scope of the mandate for the Health Policy Commission, as well as the timeline by which it is hoping that we will be able to produce some work to help inform both the legislature, the administration, and of course, the public and broader stakeholder community. And you can see here listed on this slide are some of the key subcategories of inquiry that the legislation includes. So the first two here speak to an inventory of healthcare resources, really kind of health planning, as well as an assessment of what would be the essential components of kind of an ideal healthcare system. The third bullet here reflects an interest in the healthcare workforce, in particular, and the impact of COVID-19 on our healthcare workforce and providers' efforts to train, prepare, and keep their workforce safe. There is, on the fourth bullet here, a charge that we look at how services may have changed throughout the pandemic, including the closure of certain services, as well as perhaps the reorganization of other services. And then finally, charges the HPC in consultation with the Department of Public Health, Office of Health Equity, to prepare an analysis of health disparities due to economic, geographic, racial, or other factors, and prepare recommendations and thinking about kind of how the disproportionate impact of COVID-19 across a number of range of variables, and to be able to investigate and make that understood, but also, again, to think about what are some of the solutions and advancements that we may want to pursue. Colin, I'll get to you in just one second, just to move to the next slide really quickly. We've kind of taken this really broad mandate and kind of reformatted it into an outline here of how we're preliminarily thinking about kind of weaving together some different of these component pieces into a broader narrative and story. So definitely, as is core to our mission from the very beginning, is understanding healthcare spending trends and how those are impacting the affordability of healthcare in Massachusetts, the affordability of care for employers, for individuals, for families that bear the high cost of healthcare in Massachusetts, and how we might think about what the spending impacts were both in 2020, but also in 2021 and beyond around how healthcare spending has changed and how we expect it to change in the future. Related to that, of course, is the impact of COVID-19 on the financial position of healthcare entities, again, kind of writ largely as healthcare providers and health plans, again, both short-term and long-term. An examination, as I mentioned, of provider market changes, closures, and consolidations. We expect to do a deep dive on particular utilization trends by different sectors within the healthcare system. So not just kind of healthcare or hospital utilization, but would look to think about utilization in other places across the care continuum. And have identified at least 3 areas that we think will be particular priority areas within that. Utilization trends on preventative care, utilization trends on behavioral health care, and utilization trends on telehealth. And there is, of course, some interrelatedness among those 3 particular topics. As was mentioned before, a core component will be analysis of healthcare disparities and the disproportionate impact of COVID. We also want to bring in this concept that was mentioned earlier of social determinants of health and health-related social needs, and are preliminarily thinking about bringing in the lens of food insecurity as a particular topic worthy of investigation and close examination, as was mentioned earlier, its interrelatedness to COVID morbidity and mortality. As mentioned earlier as well, there's a broad mandate for us to think about the impact on healthcare workforce and how we might make recommendations about how to strengthen and support our healthcare workforce for the needs in the future. And then that broad mandate around really thinking about the broader design of our healthcare system and what are the most essential components. So this is a very, as I said before, ambitious and comprehensive mandate for the Health Policy Commission. And the timelines that the legislature included are, again, as well, quite ambitious. So there is some expectation that we'll be able to have new data and analysis on some of these topics in the short term. Those impacts will largely be focused on what we know about what happened in calendar year 2020. But recognizing the fact that this pandemic is still very much ongoing, we don't think it's appropriate at this time to be making conclusionary statements about what the total impact of COVID has been. So we're really thinking about this as something that we'll be examining over time as data and information becomes more available. And so while we absolutely expect that we'll have some new data and information about calendar year 2020 this spring, we really see this as probably a research and examination project that will be broad in scope and will last throughout the calendar year and likely beyond, because we know that we are still wrestling with some of the impacts today. And we'll want to be careful in thinking about when is the appropriate time to draw conclusions around kind of the total impact on some of these different variables. So I want to set expectations that this will be and temper expectations that we think this will be really an ongoing work stream for probably quite some time. And related to that, to do this work, we need to really engage with a really broad set of organizations and stakeholders and voices from the community that have been impacted by COVID. And so really want to think with you all about your advice on how we might do that in a really effective way in order to ensure that the reports and research that we're producing is really reflective of that broad representation of the impacts, which of course are just daunting, honestly, to think about. And so today we wanted to begin that conversation with you to really just kind of share with you some of our preliminary thinking about how our outline and kind of work plan approach may be. And wanted to do this really at this early stage because we want your advice and guidance and counsel about what are the topical areas that you think we should absolutely prioritize, and also your advice and counsel about how we might do this examination in a way that's going to really contribute value to the public, to the legislature, to everyone here, and doing so in a way that is in alignment with, of course, all of the great work that our sister agencies are doing, in alignment with many of the work that you all are doing, and not to ever be duplicative or repetitive, but really to be a value add. And so there are so many subtopics within that outline, so many subtopics worth consideration. And so really the plan for the next hour or so is to start that conversation with you today. So I have gone through kind of a broad overview of our mandate, some of our thinking on timeline. On this slide, you can see we have a number of kind of big and weighty discussion questions. I think any one of these discussion questions could take this entire meeting. But before we dive into those, I know that there are a couple of questions and comments just on introducing this topic. So Colin, I'm happy to open the conversation up with you.
Thank you. And sorry, you're taking up a fair amount of airtime, but this is tremendously exciting stuff. And a couple of areas I just wanted to raise. Firstly, co-signing Amy's emphasis on housing in the chat. But also would love to see, at least in the final version of the report, looking at the role of obviously congregate care playing a huge role in this, and the question of transition of the share of folks who are in congregate care versus in the community as impacting this, as well as potential changes there. We're part of a coalition called Dignity Alliance Massachusetts, along with AARP, Mass, and many others, calling for policy changes in that area. I'm sure we'd love to be engaged. Also would hope that disability is included in that list of disparities. National estimates are that about 2/3 of people killed by the pandemic have had disabilities, and that's almost certainly higher in Mass because of the higher proportion of deaths in congregate settings. And lastly, I just bring up, I would hope this analysis would include looking at how hospital systems responded to the spikes in demand, as the pandemic occurred, and how they attempted to implement the crisis standards of care, because I think that is a tremendously relevant question here when we think about future crises. How did that response actually happen on the ground? How did it match up with the state's intended implementation? Thank you so much.
Yeah, thank you, Colin, and a lot there, and I'll agree with all of it. I saw in the chat a couple of people, and I hope others will speak to this as well, in terms of we had mentioned food insecurity, but I think an interest in thinking about the interrelationship between housing and security as well, with the COVID impact. And so would really welcome, as other people are commenting, to share more on how we might think about that and where we might be able to kind of add to that conversation as well. And certainly recognize that it's not just food insecurity and many other of those dynamics. So welcome some more comments on that as we go around. I think I had Carlene up next. Colleen? Or
sure. I had actually taken my hand down, but
okay.
I'll talk anyway. So I know that I think people know that MPHA has been convening a task force on coronavirus and equity. And I know that we have set up some time to talk with people at HPC. And so I won't lean in on those comments, but I do want to raise the issue of local public health. It's not the same as the healthcare system, but I think we've seen in this pandemic that the fractured and inefficient way in which local public health is organized in this state and the historic lack of investment in local public health in this state has not served us well during the pandemic. And we aren't doing anything about that right now. In other words, the way in which we're responding to the pandemic has not been to invest in the capacity of local public health. And I have more to say about that, but I'll leave it at that. And so I think if there are ways in which this study can specifically look at that issue and places where there is more capacity for local public health as opposed to places where there's less capacity for local public health, and what the outcomes in those communities look like, I think there's a there that's important to take a look at.
Thank you, Carlene, and we will follow up with you on that, and we'll want to think about what role the Department of Public Health may be also thinking about in that area as well, and how we might support and align with that work. But point is very well taken.
A lot of agreement in the chat with you on that as well, Carlene. Okay, up next we have Laura Pellegrini, Rich Buckley, and then Donna Mosh, and then Caitlin from the League. Laura?
Thanks, Colleen, and thank you, David. David, I really appreciated your opening comments. I think for many of us, we're still very much in the pandemic. Certainly our community is as people wait to get vaccinated, but for the providers and for the health plans, this is still very much a work in progress. And for the health plans, we're not going to really know the full impact of this for many, many months. So I think the study is a bit premature, but obviously the legislature has requested it. And so you can give them a snapshot in time, but I think there's much more to play out from this. I just wanted to let folks know MAP is engaged with some researchers from Harvard Medical School around telehealth and equity issues. We really won't have any findings to report, well, some early findings this summer, but we know that there are some disparities in the use of telehealth. And so I just want to raise that for your consideration as you're thinking about this report. And I know HPC is part of that work with us, so thank you. You have reported on some utilization both locally and nationally at the health plan level. And I know that the Division of Insurance over the next few weeks will be providing additional data. But what we have seen, and just so we can level set for you and for everyone, is that during the early months of the pandemic, while people weren't going in to get care, they were accessing telehealth. Telehealth was being paid and continues to be paid at the in-person rate. And as we started to reopen things, care did return back to an inpatient in-person setting. For behavioral health, telehealth was really a godsend for folks needing professional services, and we saw care at 2019 levels. So I think that some have a misunderstanding that care was not occurring during the course of the pandemic. It absolutely was, as well as the fact that the plans operationalized over 31 directives from the Division of Insurance. And we, in many instances, voluntarily agreed to give grace periods to employers who couldn't pay premiums. We waived cost sharing for testing and treatment of COVID-19. We relaxed prior authorization in a number of areas, and obviously the expansion of telehealth services in short order. So I just want to raise that. We also recently had a doubling of the administration vaccine fee. So it doubles it from the CMS prescribed amount. And I think we're the only state to do that. But I think that was a real effort by the administration to try to get as many vaccines out and get as many folks interested in providing vaccines as they could. But those are all costs that have accrued to the bottom line and were not initially built into premiums for our members. I think for the actuaries who are doing this work today at the plans, these are really challenging times. We've lost about 100,000 commercial members who are now either uninsured or have moved to Medicaid. So for actuaries who are trying to assess the financial condition of the health plan and to set premiums, it's a difficult scenario when you have employers who are laying people off or potentially need help in covering their premiums. plus you're losing commercial members off your rolls. So as they try to think about all that, in addition to, are we going to be in a third surge? When is this pandemic going to be over? COVID-related hospitalizations, is there pent-up demand? Will people be sicker when they do go to the hospital? And we hear a lot about the long haulers, like how long is that going to last for? Is that something that's going to last for somebody's entire life? Is that going to be a few months? A lot of answers we don't know. We continue to have issues around prescription drug pricing. We've seen costs rise by 33% since 2014. And there are providers who are in contract conversations with our plans right now who are seeking double-digit increases to help them as they come out of this COVID ordeal. So those are just some of the things I wanted to raise, and also just to remind people that we are our market is largely dominated by the not-for-profits. Most people are insured by the not-for-profit health plans who operate on a 1 or 2% margin every year. So very thin margins. And the 60% of our market is self-insured. And what that means to a health plan is we're not accruing any of the relief that might come from lower utilization. That is really being benefited by the employer. We get a nominal fee to do that work. So I just wanted to kind of level set that, David, for you and the team. I know you know a lot of this. As you think about this report, again, it's early to be assessing the finances, but those are some of the things that are going on right now in the marketplace.
Thank you, Laura, and appreciate all those comments and dynamics. And as you know, separate from this study, even the Health Policy Commission is charged also with doing a deeper dive on telehealth, and in particular in thinking about coverage and payment in the future. The law did establish a permanent payment parity for behavioral healthcare services, which has just been an incredible tool for maintaining access for those services, and we've seen a high uptake of telehealth for behavioral healthcare services, which has been so critical as the need has very unfortunately increased, as we know, across a whole swath of populations. In addition, Laura, looking forward to working with you and your plans to understand the utilization trends and how those are being translated into premiums. The Health Policy Commission is, of course, always very concerned about the affordability of care. Before COVID, 1 in 4 Massachusetts residents deferred necessary care because they couldn't afford it. And I think it's fair to say that we think that those challenges will only be exacerbated by this incredible public health and economic impact. And so the commitment needs to be there for all of us to continue to be committed to the benchmark, to be committed to ensuring that we have affordability of care, even as we at the same time think about how we can design a healthcare system that is really meeting the healthcare needs of all populations. And so trying to weave all of these dynamics together is going to be really challenging, but thank you for your offer of assistance and help.
Thanks. And we couldn't agree with you more about affordability, and we'll continue to identify ways that we can try to make healthcare more affordable. And certainly there are many things that HPC has talked about through the years that have not been enacted into law, like surprise billing. We'd love to see a state solution. So things like that we'll continue to work on in 2021 and beyond.
Thanks so much, Laura. We've had a number of great comments in the chat. Encourage everybody to try to get those on the record. If we have time, just raise your hand or let me know. I'm going to call next on Rich Buckley, and then in the queue I have Donna Mosh, Caitlin from the League, Amy Rosenthal, Mike Caljo, and Matt Vino. And just because, and I should have said this at the top, because we have some new members, please introduce yourself, your name, and your organization so everybody knows where you're coming from. Thanks. So Rich.
Great. Thank you so much, Colleen and David. Rich Buckley from AstraZeneca Pharmaceuticals. Nice to see everybody and welcome to the new members. I'd mentioned this, I think the last time we met, but I think it's all the more relevant now, which is we've been working with the London School of Economics and the World Economic Forum since last summer on exactly this topic. There's been sort of a grand research project under the banner of the Partnership for Health System Resilience and Sustainability, looking at case studies and meeting with academicians and policymakers across 8 countries so far. It's France, Germany, Italy, Spain, England, Poland, Russia, and Vietnam. And looking at resiliency, which is about responding to shocks like pandemic and natural disaster, but it's also sustainability, health system sustainability, which is more about how do you manage and mitigate more foreseeable things like chronic disease and infectious disease. And the study's been ongoing. There's a summit that's open to the public in March, which I'll send you the link to. But looking at many of these exact same topics: governance, financing, workforce, medicines and technology, and service delivery, among other things. So it seems like it's directly on point. And knowing that sometimes the difficulty in jumpstarting a research project like this is thinking about, definitions and, as you said, scope and what's in and what's out and how things are defined. I would commend that you take a look at the research that's been going on here, which you can react to just as a straw man and compare whether or not there are definitions you like or areas that are in or out of scope that you find useful. But anyways, an opportunity to not necessarily recreate the wheel. So Colleen and David, I'll send you the materials. You can share them as you see fit, and maybe useful, for somebody to maybe even participate or watch the summit, which is in March. It's like 3 days, policymakers from around the world talking about exactly this. It may just be a catalyst for your thinking.
That's great. Thanks, Rich. And I think pivoting off of that, and ask to everyone on this advisory council, there's a lot of activity in analyzing impact of COVID. Please let us know when you see things that are exciting, that are interesting. If you have done survey work with your own members, with your own organizations that you think that can help inform our work or be part of this report, we welcome it. There are obviously many areas of data gaps where there is not systematic collection of some information. And so you and the associations and organizations are really well poised to be able to help us find the best information. And we're really not trying to reinvent the wheel here, but really trying to learn from all the great work that's going on. So it's a really great point, Rich, and a pivot to an ask of everyone here.
Okay, Donna?
Hi, thank you very much. I wanted to comment that as you undertake this, one of the, as I put in the chat, one of the major results of the pandemic is a behavioral health epidemic that's arisen in the context of the pandemic. And as Laura said, the healthcare system, in the case of behavioral health, ambulatory care pivoted pretty quickly to providing telebehavioral health. And while other ambulatory medical care demand was reduced, it actually increased in behavioral health. Since the tail for recovery from the behavioral health epidemic is going to be longer than the public health aspects of the virus pandemic, it's very important that you're looking at this now. And this is not just about new demand from people who didn't have pre-existing conditions, but have developed anxiety, depression, and traumatic stress from the pandemic. It's also disproportionate impacts on people with pre-existing conditions. And to the point Colin made earlier, on people with disabling behavioral health conditions, almost all of whom have complex and multiple chronic health conditions. A new study just released shows that after age, the diagnosis or condition that most aggressively predicts death from COVID is schizophrenia. And a group of us have gotten together to ask the administration to consider elevating that people with that diagnosis for vaccines. But there are many with other diagnoses that have these complex conditions, and the challenges for care delivery during the pandemic have impacted them as they have others. So the last thing I'll say is I do not envy you the task of trying to map the entire healthcare system. If I understood correctly what was presented on a previous slide, and having worked with 6 different state agencies and other collaborators to establish the database of behavioral health and related services in the Commonwealth, of which there are over 5,500, I would note. I'd be happy to share the agonies and ecstasy trying to gather and clean those data.
Agonies and ecstasies is right, and having been a part of other in my career earlier health planning efforts to try to map resources, and it is a huge challenge, as everyone here knows. So that will probably be that charge in and of itself is going to be a big lift for us to try to put our arms around and really think about, you know, where can we add value there, and not just having a list of sites that is out of date the minute we post it on a website. And so, you know, look forward to further conversations on that topic. It's a big one.
We're happy to help.
Okay, Caitlin is next, and then Amy Rosenthal's on deck.
Thanks so much, Colleen. And Caitlin McColgan at the Mass League of Community Health Centers. Know many on the call, and I think I've covered this call before a couple of times in the past, but not in a long time. I'm not a member of the council, but an occasional designee as requested. So I'm just here today for this really important meeting, and apologies, I missed the first few slides. I think like a lot of folks on this call, kind of quadruple booked these days with vaccination efforts. Just wanted to kind of, I think to the first point, David, on the slide here about, you know, particular impacts on sectors and communities and populations. I just don't think we can really emphasize that enough. You know, I think throughout the pandemic, sometimes our members have felt, and probably so many people in different communities, that we're really living in 2 different universes during COVID. And we, just as an example, you know, pull testing positivity rates from health center EMRs through a data system that we have, and, you know, get that report. We've had it at different levels of frequency throughout the pandemic. Now we're kind of on a monthly basis, at other times weekly or biweekly, and we stratify by region, race and ethnicity. And it's just not uncommon for us to see positivity rates in the 20s, you know, close to 30. In February, we've seen positivities in the double digits in many of our populations and regions, in the high, you know, teens. And, you know, even as obviously our state numbers are coming down, you know, to more hoped for levels. So I think, you know, just the parallel universes, and then all of the many ripple effects that has on people, and then how they engage with the healthcare system and how the healthcare system has to respond to them. So, you know, as a kind of example of that, you know, I think folks probably know, for our members, you know, really feeling like they had to respond to really shift to a COVID response model with testing, tracing, treatment. And, you know, we've just been more intensively engaged with them than probably ever before. And, you know, many calls a week with CMOs and our testing leads and our tracing leads and all of that. And just hearing about, you know, just the sheer volume of COVID cases, right, that many of our primary care docs were managing at any given time, you know, sometimes 30, 40, 50, 60 cases of high risk people at very small organizations with complex social issues, you know, housing insecurity, you know, cohabitating with like large groups of people, food insecurity. And for every one of those COVID positive cases, you know, clinically managing them, but socially managing them, and what that strain put on the organizations as they're trying to kind of wrap care around their patients, and, you know, each one of those being complex. So the ripples of that, you know, have been immense. And, you know, some of the related ripples in terms of shifting our workforce to COVID response, you know, have really manifested in a way that we're concerned about impacts on quality. You know, as we look at case managers and community health workers, you know, have been pulled into so many other functions, our MAs who have been our swabbing, army of swabbers across the Commonwealth doing community-based testing. Those are the same MAs who would normally be calling to remind you about your pap smear or, your overdue mammogram and things like that. And so how is that going to ripple out in terms of quality from a provider perspective, but, exacerbation of disparities from a patient and community perspective. So, it's heavy, and it is definitely something that we hear from our providers and our leaders every day. So just wanted to kind of offer that. And I think, the last piece, which is related to that, is just kind of the system impacts of this going forward. Laura spoke about long-termers. We're just so in it right now. It's hard to really even, think, but we know that that's coming, especially with patients who rely on, going to work every day. And what are the impacts of that going to be if they are not able to do that? And then all of the many impacts on their health and obviously their insurance coverage. So a lot of related pieces, but I think just that prism of the parallel universes of those communities that have been hard hit versus just the general experience, even, as Massachusetts overall, we all feel like we've, lived through this, but it's just such a concentrated impact in certain communities.
Thanks so much, Caitlin. Okay, Amy Rosenthal, then Mike Caljo.
Hi, everyone. It's Amy Rosenthal from Healthcare for All. Appreciate being part of this good discussion. So many things I want to echo, Donna's points about behavioral health. Obviously, we are strongly agreeing with that and glad that that's being pulled out in the report for sure. Also thinking about disparities and particularly about race. I'm glad that we have new council advisory board members who were great at articulating that right at the top of the meeting. I want to reiterate the importance of that for sure. A couple of other things that I wanted to pull out that I'm pleased are in the study and want to make sure we're really thinking about. Consolidation is obviously something that I think a lot of us have been thinking about. Pleased that that was specifically mentioned, as we know, because of the long-term impacts on costs as the consolidations happen more and more. And I think that gets us to this issue of affordability, which is really top of mind for Healthcare for All. In the upcoming year, I think David, you were the one that said that, now more than ever, we need to be thinking about this for consumers. We've all taken a hit in terms of business and industry, but individual families have really felt the hit, and it's going to continue to be like this for some time. I think this is a real opportunity to look at the HPC process, to take a step back and think about opportunities for enhancements and improvements. We think that this has to be done across the board, and thinking about all of the cost drivers that we know lead to the increased costs and the high costs here in Massachusetts. So whether it's thinking about prescription drugs, thinking about the role of insurers, thinking about hospitals, high cost hospitals, I think all of those things are things that in the next year or so we should be looking at at any rate. Also want to reiterate what I put in the comments about housing insecurity. I think that there's a particularly important opportunity here. The ACOs have been really focused on this, and Healthcare for All and MPHA have been doing a study over the past couple of years about the ACOs and the work in both housing and food insecurity. And we know that the housing piece is really hard to tackle because of the tremendous costs that need to go in there to try to address that issue. And so I think that when you're looking at across the healthcare system, as you'll be doing, and looking at the issue of housing, there's more opportunities to think about how we can be drawing on resources to try to address the issue of housing. And last but not least, I will mention, and I wasn't sure if this was actually in there, or maybe it's in there in the subcontext, but in the Merge Market Commission, we've looked a lot at data about how the COVID pandemic has shifted people off of employer-sponsored insurance and into public health, public programs. And we're fortunate in Massachusetts that we have such a strong health safety net here. But I do think that putting really looking at that and understanding what went on during this pandemic and helping us kind of reaffirm and understand why it's so important that we have that strong safety net is really important. And if that's not necessarily in the study already, I would encourage you to think about including that. Thanks.
Thanks, Amy, for all those comments. Just to pick up on the last one, I do think that the, change in enrollment is an important part of the story, and both from a safety net perspective, but also from a financing perspective about our healthcare system and how that may change and the pressures that may put on organizations, new pressures. Appreciate that. Thank you.
Thank you.
Great. Okay, so now we have Mike Caljo, and then on deck, Matt Vino, and then Steve Walsh.
Great. Thank you, guys. And again, I'd echo the appreciation for this dialogue and the energy that this group brings to bear on the topic. I have a comment about process, and then I have a suggestion, particularly for the interim report. My comment on process is that as agencies have looked into some of these issues already, we should try to utilize as much as possible work that has been done at CHIA and at the DOI or within the HPC on a number of these different topics, and understanding that each of the healthcare entities are still under the crush of the pressure of responding to new and different data requests. I think it's more important than ever to use that administrative economy of effort and scale to lead to these efforts. My second comment, and I took from your comments a willingness to do that already. I want to focus on point 2 on the slide that's still presented, which is any recommendations for prioritization for near-term examinations, because I agree that a lot of the topics brought up, almost all of them merit consideration. You're left with the Hobson's choice of what to come up with in the short term for this April, or if it drags a little bit into May, interim report. I would suggest, based upon what we're seeing in terms of claims demand, as well as what you heard today on this call and what we're seeing in the marketplace, you could slice into the behavioral health issue at an early stage, even in the interim report, and try to do a lens into that from each of the participants in the market and get feedback from the market participants. And it may not be data driven, but it might be a good way to illustrate a key concern that you heard expressed today on this call, but is definitely out there in terms of the just explosion of behavioral health needs stemming from the COVID-19 impact. And if nothing else, it leads the reader into wanting to explore those issues even more for the final report. I think if you try to do too much in this interim report, or if it's just a catalog of issues, I think it's a missed opportunity to really delve into that behavioral health care explosion and service demand. And people are hurting out there. And I think your lens is an important one to help add to that and draw out this particular experiences of each of the participants, us from claims, hospital systems, community health centers, any number of the different categories, and kind of use it as an illustrative tool for further thought.
Thanks, Mike. And yeah, I appreciate the feedback on that question, because it's certainly one that we're wrestling with. And as I said earlier, I think we are trying to temper expectations that we're going to have a comprehensive interim report this spring. That is just not realistic. And so where are those topical areas that are where we do have some information to bring to bear, or to be reflective of what we don't know yet, but expect that these will be topics that are worthy of further investigation, and do some signaling on those areas. So agree with you. And as I said earlier, the timelines on all of this, will be driven in many ways by the availability of information, and we're still in this. We are still in this. Caitlin said this earlier. We are very much, hospitals, community health centers, providers. Everyone is still working very hard at this every day. So, we're thinking about. We do think that we'll have some information about what happened in calendar year 2020, but certainly that will not be a definitive statement about the full impacts here. So where are those areas where we can do some signaling, where we can bring topics, prioritize topics for further investigation, and work with our sister agencies and others to do so. All well taken. Thanks, Mike.
Okay, so next we're going to Matt Vino, but just a PSA quickly. I am saving the chat. There's a lot of substantive comments and questions in the chat, but if anyone would like to raise those comments to the group, please do let me know. We do have time. So, okay, Matt Vino, you're up next.
Thanks, Colleen. So I want to second the comments that Mike Calger just made around behavioral health and making sure that rises to the top of your areas of focus here. It's an area of great concern, I think, to everybody, and having some texture, even if it's qualitative at this point and not quantitative, I think that would be a real contribution in the short term. I'll preface my next comment just by acknowledging that we are most certainly not out of the woods here, as everyone has said. Still all hands on deck, particularly those that are providing direct care in our physicians' offices and hospitals. So I think it's important to continue to acknowledge that, and I certainly want to do that. So as it relates to sort of question one about impacted industry sectors, again, I'm sort of seconding other comments, but Amy's comment, Amy Rosenthal's comment about the impact of COVID potentially to lead to further consolidation in the hospital systems, in provider, physician systems, et cetera. Those continue to be a really key element of the operation of our system as a high value system. And so I think having a sense at least of the dynamics that are happening there, certainly well within the wheelhouse of HPC to understand that impact. On number 4, around the examination of health disparities, again, given the limitations of bandwidth to accomplish all of this in a short period of time, I think focusing on data, as you indicated earlier in the deck, makes a lot of sense. Focusing on standards and developing data standards, that will, of course, again, also right in the wheelhouse of the HPC. And it feels to me like you all can play a really central kind of leadership, coordinating, convening type role there. We are really excited to work with you on that. It's made a high priority of mine and my commission coming in. I would say on the short-term impacts, I do just want to note that we may have an opportunity with our claims data, which comes to us pretty quickly in the near term, might be a resource that you could use to supplement the data systems at CHIA. So if there's an opportunity for us, even if it's just at kind of macro level trends around utilization, that might be instructive and helpful for folks to understand the impacts. We literally get claims at a pretty high level on a weekly basis from our carriers. And I think and then the other thing just around behavioral health that really does concern me, and I think this may have been in a report that you all put out, was the kind of persistently lower usage of behavioral health services among the younger population. Just to see that a significant chunk of that care just didn't happen for a period of time, and it's been slow to return. I guess I would put that in that first category of items that I mentioned, that Mike mentioned as well.
Great, thanks so much for that, Matt. Appreciate that. Okay, Steve Walsh, and then Dr. Dunlap and David Mattiotto.
Thanks, Colleen. Thanks, David, and certainly really appreciate that this is in the hands of you and your team, because I know you'll take great care. I'd echo a couple of behavioral health comments first. Donna, thank you. Michael as well, and also Matt. I think that is an area that you really can dive into that needs response immediately. And we haven't yet figured out, even through this pandemic. I think Donna said it right. It is the epidemic within the pandemic. And it is a huge concern. To Mike's point about stakeholder engagement, I want to agree with him. I do. Caregivers and providers are fatigued, as all of you are, to reach out to stakeholders at this time while we're still in this. I think it is going to be very difficult for people to be able to give the time and attention that ultimately a report like this will deserve. I think at the last advisory board meeting, I said we were at intermission, and I don't think the play's over yet. And I don't mean to compare this to a Shakespearean theater, but there's a lot that happens in the final scene, and we're still not there. We're 351 days into the public health emergency. It has not been rescinded yet. We are still very much in the middle of it. In 4 of our 5 regions in the Commonwealth, we're still in surge. As of last weekend, we were still moving patients around because of a capacity challenge in various regions, and we still aren't scheduling events at our providers, right? We still are not doing elective service or scheduled events. So we are still very much in a state of emergency here in the Commonwealth, and all of you on the call are working very hard at vaccines and making sure we get those to the right people, taking into account safety, equity, and making sure that we are all reaching out to communities that need to be vaccinated. And the only thing that has held us back in many ways has been supply. So I do agree with Laura that it was a little premature, but I know that you have the task in front of you and you have deadlines that you must meet. And I hope we can just keep those points that have been made about the timing in mind. I will also thank Laura for her comments on telemedicine. I think that it has been incredibly helpful. I will say that it has not been the panacea about patient care and finances that some have suggested. And I point to a Becker's report that came out earlier this week. Massachusetts did come in first at decline in hospital volume. Now that means 2 things. It's going to mean 2 things as we come out of this pandemic together. It's going to mean that our hospital systems are going to be weakened financially. It's also going to mean that our patients are going to be sicker because it means that they have deferred care. So if you can talk to any of the hospital CEOs or provider CEOs on the call or doctors on the call, they'll tell you that the patients that you're seeing now that come into their hospitals, their clinics, or offices are sicker than they might have been had they not deferred care. So that's going to be a problem for us as a Commonwealth as we move forward and we get this behind us. And I know we all want it to be behind us. It just isn't yet. And I think we always have to keep that in mind, as I appreciate David, you and Colleen doing. And I want to thank Colin for his comments earlier, not just today, but throughout the process in the crisis standards of care. He and his team helped make them better, improve them, and help shape them. And I will say, thankfully, they never needed to be implemented here based on the incredible work of our caregivers, our hospitals, and our providers. But it was Colin and his work and others that made that a better document. God forbid we would ever have had to use it. And I think he's right to make sure that we continue to explore how to make that even better and more equitable moving forward. So thanks for giving me a little time today, David.
Thank you, Steve.
Dr. Dunlap.
I wanted to comment on the lack of a strategic plan for both testing and deployment of the vaccine. Back in July, I appealed to the HPC that we should develop a strategic plan for deployment in the highest impact communities for deployment of vaccines. And so now that we've shifted to mega centers or large centers, that is further accentuated the lack of the ability for communities of colors and for communities impacted by this, the COVID-19 epidemic. So even the most sophisticated patients and citizens are having difficulty signing on to and getting an appointment for a vaccine. Now that we've removed the community groups and not deployed the federally qualified centers and other local access points for the vaccine, we're really making the gap for communities of color in accessing vaccines greater. So there really has to be a way to allow people who don't have good access to computers, who are not sophisticated in terms of accessing the system, to get the vaccine. So I think that we could play a role in that. We have the New England Medical Association, which is an NMA group, trying to play a role. Now, one of our president of that association is now moved to the Reggie Lewis Centers to try to help in accessing patients of color to the vaccine, but they only have 20 phone lines. So I think that somehow the governor has to really look at making it more possible for lower income people to access vaccines, and that has not been done.
Thanks, Dr. Dunlap, for those remarks. We really appreciate that. Okay, so we have David Mattiotto next, and then Lisa Gorgoni.
Thank you very much, and thanks everybody for all the comments on behavioral health. And I'll be brief to not be redundant, but I wanted to just kind of give my colleagues here in the HPC, which may already know some of this, just some detail on this issue. As of last week, last Wednesday, we had, just for Mass Health alone, 300 people waiting for a psychiatric bed in Massachusetts. That's just Mass Health. Doesn't include the private. 100 of them were child adolescent, of which 65 of them were waiting longer than 96 hours. So Steve Walsh is very familiar with this from the emergency room pressures that we're seeing. We also are experiencing difficulty keeping the unit staffed because of outbreaks, and we had, as of last week, 12 units closed to admissions. 3 of them were child adolescent. So you can see what's happening here. We're about 500 beds below licensed capacity in Massachusetts because of staffing issues, and we're really working hard with the state. I will say that Mass Health particularly has really stepped up and put some new resources into developing beds. We hope for at least 3 units coming online this spring in the next few months. So hopefully better days are coming. But I think, we think that especially child adolescents have really experienced some tremendous pressure, probably because of, I'm not even a clinician, so probably because of school closings or whatever. We're seeing, this is really unprecedented. I've been in this position 30 years. We've never seen anything like this. So, and it's ironically, out of 2,300 beds last week, we only had 31 COVID patients, 31 positive. So this is impacting not just with COVID. Of course, when it happens in a psychiatric sector, it can often lead to closing a unit. So it's not just the COVID though, and the strain. I've heard the governor talk about the strain it's putting, especially on kids. He's 100% right, and they are stepping up, the administration. So just wanted to put that color on it. Thank you.
Thanks so much, David. Okay, Lisa Gorgoni.
Hi, thank you. Yeah, I just wanted to make a few comments related to behavioral health, and I certainly agree that that's a priority. I put in the chat, we found with a lot of the older adult population and also communities of color that, the move to telehealth for BH has been kind of challenging. And I think it's so important to keep that in mind when we think about, how do we look at how we serve populations that may not have access to the technology that others, and even when we provided access, quite honestly, they still don't know how to engage. And so it's more than just giving someone a device. So I think that's really important. And also not just the patients, but also their caregivers. So for instance, one of the industries in the home health sector or the home care sector that's been significantly impacted by COVID is the adult day health sector. I know the Commonwealth has done a lot to support that sector, but they've had to close and significantly reduce their ability to take in new people. And that has led to a lot of strain on caregivers and additional BH issues for caregivers. They're not having that respite opportunity. So I think that's just important to think broadly too about the healthcare of those caregivers, and obviously how that impacts them. And then the last thing I will say is workforce. We actually just surveyed all of our ASAPs, and we have right now today, there's about 3,000 consumers in Massachusetts, older adults, waiting to be partnered with a home care worker because we can't find services. So we're seeing a growing wait list because there's not enough home care workers, similar to what David was saying about behavioral health workers. So there's just this whole workforce issue. And I think it's a combination of a lot of things. Obviously, people, there's other options for people, unemployment, there's childcare issues, our workers tend to be women. So it's just a lot of things, but there is a huge workforce issue, which I'm glad to see on the list. I agree with everyone. You're not going to be able to do all the examination of all these issues, but workforce is a big, big challenge. So I appreciate being able to share that too.
Thank you, Lisa. Colleen, do we have any other raised hands?
We don't technically have any other raised hands, but we had a lot of comments in the chat. So I don't know if anybody wants to put those to the group.
If there's anyone who hasn't had an opportunity to speak yet and wants to share a few thoughts here at the end.
This is Kim Brooks, Hebrew Senior Life. I put this in the chat. I just, the scope, it's already seems like a daunting task, but just as you think about, we have this definition of healthcare system and healthcare resources, and certainly a lot of, work happening out in the community and community-based organizations. And maybe out of all this, we'll think about some creative ways moving forward for those partnerships to be strengthened so that we can take advantage of all the work that does happen kind of outside of the technical healthcare system. So just to keep that in mind.
Yeah, thank you, Kim. And certainly the importance of some of those services and supports beyond what we traditionally think of are just so apparent throughout this time period and will be even more necessary moving forward. So how do we think about the partnerships in the community beyond what we think of doctors' offices and hospitals, of course. Dr. Strongwater?
Yeah, I really appreciate the quality of this conversation. The point I would want to make is that the impact of deferred care is going to need to be followed over a long period of time. There is going to be a tail on that deferred care. So just keep in mind, whatever you find now, you're going to have to keep studying it for a longer period of time.
Thank you, Dr. Strongwater. I think a great way to close out, we have Dr. Clark.
And I'll be very brief, but I definitely do not envy you the task of trying to boil all this into a report. And so I appreciate the scale and scope, but I would say that as you put this together, there are very few voices, I think, that can make the case for health-related social needs and the social determinants of health as a part of healthcare, the way that HPC can, and sort of lend that weight. And as we think about things that have been put in the chat around health-related social needs, particularly the economic insecurity and the economic opportunity pieces undergird housing, they undergird food insecurity, and it really, in many ways, also the stressors that contribute to some elements of behavioral health. And it really does drive care and utilization. And so anything that we could do to highlight those points in the report, I think would be useful. Good luck. But it's going to, I think, be both currently and over time an important thing to look at. So I appreciate that you're doing it.
Thank you, Dr. Clark. And again, yes, the scope here is broad, and I think part of our challenge is going to be, really identifying those areas where the Health Policy Commission, in particular's expertise, can really add value. And there may be other topical areas that have been raised here today and beyond that are most appropriately kind of examined by other state agencies or other organizations where that necessarily may not be our area of expertise. So I think of the last hour and a half as a pretty incredible virtual whiteboarding session with all of you, just putting all of these ideas and comments kind of on the table. I think next steps will be for us and our staff to probably rewatch the YouTube video 1 or 2 more times to catalog all of these comments and ideas and start to map out, what we can do, where we can add value, and on what types of timelines and where are the information gaps that we'll need to be able to fill in order to, to really contribute over really, let's be honest, this is going to be this whole calendar year and probably all of next calendar year working on many of these topics. And I take it whenever someone on this group makes a comment that is also an invitation for us to follow up with you and to have a deeper, longer conversation. So thank you for all of those invitations today, and expect to hear from us. Being respectful of everyone's time and knowing that we could do this for another hour and a half or 3. I will wrap it up there and just thank everyone once again for everything that you are doing and your organizations and the people you work with every day for the residents of the Commonwealth in treating both COVID and non-COVID healthcare needs and getting our residents vaccinated. Thank you, thank you, thank you. And we look forward to our partnership